Yeah, ladies and gentlemen, dear Adel, thank you very much for this invitation. It's really a great honor to be here since now almost 10 years now, since 2012. This cooperation between EGA and AGA is wonderful, and I think it's really a lot of other countries can learn about that. So thank you very much. Yeah, what is really the problem today? The problem is that we have a high failure rate in rotator cuff repair. About 40% is failure, but only one-fourth, 25% get a revision surgery. Why have we this discrepancy between that? We have some risk factors, and we already know that. There's the tendon stump, the defect size, the fatty infiltration, smoking, steroids, diabetes, age, more than 65 years. These are really the risk factors why we have such a high failure rate. The second problem is the biceps tendon. In this study now, when they had 60% ruptures, and about 50% they had a problem of the biceps tendon. So if you do it endoscopically, you shouldn't miss the biceps tendon, the so-called hidden lesion. When you look at this here, sorry about here, you see the subscap here, the biceps tendon, it's cutting into the subscapularis, and you may miss it when you do it open. So do not perform a slab repair if big rotator cuff lesions. The biceps pulley, if it's affected, always perform biceps surgery. And the MRI shows a low sensitivity because at arthroscopy you can see it much easier what happened with our biceps. So reason due to surgical technique is the second point. The insufficient acromioplasty, like here, if you take too much, like 2 centimeters here, that's far too much, they get pain after. If we do not really fix it and we do not mobilize the rotator cuff, that's the biggest problem, because then why can the tendon heal? And surgical technique is also a problem is anchors. Titanium anchors you may see, bioabsorbable anchors you may not see, but this is the same problem. Then not insufficiency and osteolysis of the major tubercle. So that's just one case now, 1 year post arthroscopic surgery, side-to-side repair, and it failed. And when you look at here, why it failed, you see that fixation was not so bad, but it failed here. We have mid-substance tear, that's the worst case, when it ruptured here between the tendon and the muscle itself. So how can you fix it here? So this is a worst case. So we have to revise it, and what we did here, we revised the subscapularis in a double row fixation. As you can see here, we fixed the biceps tendon and also the supraspinatus with a speed bridge technique. We can just close this. So remember, it's not only supraspinatus, it's also subscap sometimes. The big problem is also infection. Only if it's between 1 or 2%, but in a lot of cases we have this low-level staph aureus and propionine acne, low-grade infection. If it's more risky in an open procedure than in an endoscopic procedure. And look at this case now, a smoker, he had some reconstruction in a mini-open, he fell on his arm just 6 months later, and now, what happened now? Still the anchor is here, the tendon is here, why did it fail? And we started to clean it, and then we realized we had to clean and we had to take out all these anchors. We did debridement, and even after 3 endoscopic debridement following initial revision, we could find some propionine in the sonication. So this low-grade infection might have been a reason for failure in this case. So what about the stiff shoulder? About 5% they get a stiff shoulder after rotator cuff reconstruction. What are the risk factors? PASTA, workers' compensation, tendinitis, calcarea, decreased motion before you do the surgery. However, the retear rate is quite low, 5%. But remember, stiffness can be a problem. Here, this case now, 50-year-old male, he had a speed bridge repair, and then he fall again after 3 months. And now in a revision surgery, we just did an arthroscopic arthrolysis because he got stiff, but everything else was perfect. So when you go in and you see how it is, you see the redness here in the rotator interval. Here's the subscap, here's the supraspinatus, and you see now you can release quite easily with an electrothermal device. You get a full range of motion back. What is the main reason for revision in our department? So we had 60 revision in 10 years now, or out of 600 repairs. Mean age was 59, mostly male. Initial surgery was external. 50% had initial surgery arthroscopic, and some of them had 2 or more previous surgery. So in about 60%, it was a re-rupture, really a true re-rupture, but also 18% had an infection at that time. So keep this in mind, 18% can be an infection, and you may miss it. So what is our strategy? Biological healing potential, this is one of the most important parts. Then tendon muscle quality, retraction, retrauma, diabetes, smoker, surgical insufficiency, and low-grade infection. I think you shouldn't forget it. What these are our options? Partial repair, transfer, debridement, or total joint, transfer like latissimus, or arthroscopic mini-open repair. Always remember the biceps tendon, sometimes release the suprascapular nerve, because then, you know, when you have a retraction, you also have a retraction of the suprascapular nerve, and that's why the supraspinatus will not work. It's a clear indication when I perform the traumatic rupture, fall or dislocation again. But keep in mind, important is also the physical therapy after that. Include other reasons for pain, like the cervical spine, the scapulothoracic function, infection, adhesive capsulitis. In a case like this, I started to do a non-operative treatment. He had the first reconstruction, delayed rehabilitation, or pain on the load at night, even after 5 months. A small rupture, but a massive scapular dyskinesia. Scapular Alcystin test is positive. So don't do revision surgery in this case, because this is somebody who really needs a good physical therapist. What we have seen yesterday from Angelina yesterday, just try and work on the scapula and the scapular dyskinesia. Physical therapy is the most important part. Scapular setting, stretching of pec minor is so important. Why I do perform an arthroscopic procedure? Because we can evaluate the glenohumeral joint and the space. We can test the biceps tendon. We can treat subscapularis. We do not destroy anything of the deltoid, and we really can see the rotator cuff, and we have less postoperative stiffness. Should you do it arthroscopically? Yes, but sometimes it's important to remove all these artificial implants, like big sutures, plates like here. Transversus repair, it's sometimes easier in a mini open when you have to release everything and remove all these kind of anchors like here. We need different anchor material. No, we don't need bigger anchors. Sometimes you just go through the bone and you can fix it. So in these cases, I recommend to use an additional CT scan. Then you understand why it's a problem, because now you have a big osteolysis here because of the absorption of some anchors or some infection. So CT scan is a good help. We also have to look at the tendon itself. What is the quality? What is the type of rupture retraction? Can we really bring it back to the footprint? Like here, when you have a mid-substance tear, it's impossible to bring this here, but you can still close it side to side. But then you see that it's not only the supraspinatus, it's also the subscapularis here, because we have a retraction here. Watch out for the elimination. So change the scope to the side. Look at the side. Here you see the supraspinatus, where there are 2 layers, inferior layer, superior layer. So watch out and bring this back to the footprint. And then again, from inside, partial rupture, when you have seen, these are the 2 layers, and you have to do it to fix it both at the same time. So in this case now, female, he had an arthroscopic fixation, mini open revision, and then fall again, arthroscopic subscapularis repair, because they missed it. You see now how I can do it. And in these cases, we try to fix it in a double row fixation, subscapularis, because the subscapularis had a huge insertion site on the minor tubercle, like the state of Nevada. So acute rupture of subscapularis, delayed reconstruction, and then re-rupture again. And you know why it ruptured here? Because the release was not sufficient. So we treat it here again with a double row suture bridge fixation for the subscapularis. It needs some time because you have to release everything. You have to use some traction sutures to bring the original subscapularis back to the origin. And then you can use some swivel locks like here with fiber tapes going through the tendon, and then you can finally fix it quite nicely, as you can see it here. In this schematic drawing, the speed bridge, you also can use this on the subscapularis. You need additional portal in the front, 2 lateral, 2 anterior, that you get a nice retraction. Technique of subscapularis supraspinatus repair, again, think about the 2 layers. We have here the border between cartilage and bone. Here's the first anchor, and then we use the fiber tapes going through the tendon on different level. And finally, sometimes it's important to use an additional portal like the Nevisor portal, double row fixation with 4 swivel locks, 2 tapes. You really can bring back, you can release the suprascapular nerve here and use this portal to release everything. So finally, keep in mind the most common reasons, too fast. So the most common reason for revision is stiff infection and non-treated additional pathology. Don't forget the biceps tendon, and don't forget the subscapularis. Always add arthroscopy to revision surgery. Not every rupture needs surgery, and optimal analysis and diegetic planning is needed. So then also remember, the revision results are not as good as the primary results. So you have to tell this to the patient. So thank you very much for your attention.